Words matter in mental health care, and using the right language is about much more than clinical accuracy. Chosen skillfully, our words can build trust, reduce stigma, and improve patient outcomes. What's key is learning to identify and replace potentially harmful language with clear, empathetic, and respectful communication strategies. Our guest for the session has a wealth of experience using impactful language in clinical settings. Dr. Christine Tibaldi is Chief Nursing Officer at McLean Hospital and Vice President of Nursing for Mass General Brigham Behavioral and Mental Health. As an active member of the American Psychiatric Nurses Association, she has served in several volunteer leadership roles, including as a board member at large. Dr. Tibaldi is recognized for her expertise on topics including patient-centered care and stigma reduction. Christine, thanks so much for making some time for us today.
Hello, it's so nice to be here. Thank you so much for having me.
Well, we are thrilled to have you with us, Christine. Before we get into specifics, bottom line for us, why is language so important in mental health care?
Well, you've already said some of the most important things here. Language matters. It really, really makes a difference. And when we communicate with our patients, our colleagues, and so on, we're intending to relay respect. We're intending to communicate something that is very trauma informed. And while we're going to focus on the words and what we say, I'd be remiss if I didn't say something about how we say what we say. That really communicates something that is equally important. We want people to feel like they are with us, engaging in a shared goal-setting process. And the language matters, and the way we say it matters.
We're going to drill down on those topics and speak a lot about the one-on-one relationship between a professional and a patient. But let me ask you a broader question in terms of the whole field. What about stigma and bias within the mental health field? How are they impacted by language?
Yeah, it's such a great question. And while there's been lots of advances, there's still quite a lot of stigma and bias in society today in the work that we do. And actually, the question, Jeff, reminds me of an experience that I had as I was working in an emergency department. So I'm a psychiatric nurse practitioner and have worked over the years in emergency settings. So individuals coming in crisis at times. And they may not be thinking clearly. They may have had an emergency event, and their behavior may not be what their normal expression, experience, presentation would be when they're feeling well. And in working in the ED setting, I would often find that people would really, who are on the staff, and maybe even other patients or family might look at an individual who is suffering from a behavioral health crisis more around their diagnosis or the behavior, and not as a person who's having some particular exacerbation of their illness. And it was just always so striking that those thoughts and feelings weren't the same if somebody came in after breaking an ankle or after a car accident or a heart attack or something like that. That as though the individual was somehow in full control of the presentation, unlike those other more physical related conditions. And so what we would often find is that would contribute to people saying unkind things, referring to the person as their diagnosis or their behavior, and actually having those interactions that would actually exacerbate the situation instead of stabilize it. And so one strategy that we would often use is actually taking time out and talking with the staff and sharing really what's going on, what's at the root of the behavior that they're seeing, and what's at the root of the presentation or diagnosis that's been made. And so often that would actually yield people really making a shift in their thinking and say, well, I can see that I'm actually the words I'm saying are really actually not thinking about this individual as a person, as a human, and those interactions would become better and more productive. And inevitably, in those conversations, we'd find out that one of those staff members also was affected by mental illness or substance use disorder in some way, shape, or form, whether it be that they had lived experience themselves or a loved one. And as people began to think, how would I want to be treated? What are the words that I would want used about me in my care? You began to see that shift, but it's still very present, and there's a lot to do in this space.
Christine, you just touched on this. I want to zero in a little bit more on this concept of person-centered and identity-affirming language. What about the shift from illness first to person first language? Can you say a little bit more about that?
Yeah, it's been a really interesting process, and I can say in the span of my career, we weren't always like this. We were often as clinicians really speaking more about the diagnosis than the person. So when you mentioned illness first language, sort of leading with the depressed person, the bipolar in room 22. There's no human, there's no person. And when we do that, we actually make the conversation, the interaction, the perspective, we make it about the illness and not the individual. But when we use something called person first language, where we say it's a person with depression, a patient with schizophrenia, we're actually starting with the whole person and really setting the stage to say that there's a lot more to this individual than just their diagnosis or their illness. Very similarly, when we think about physical conditions, we don't start the conversation by saying there's a canceric receiving care. In the room down the hall, we really talk about that person with dignity and with respect, indicating that there's more to them than just that cancer diagnosis. And the same is true about mental health and substance use diagnoses. There's way more to the person, and actually knowing that helps to promote recovery even better.
Let me ask you a two-part follow-up to that. Do you
Sure.
ever ask a patient how they prefer to be identified? And what do you do when a patient is using outdated or stigmatized language to describe their own condition?
Yes, and I think what I'd like to say is yes, every time. I start a conversation with asking the patient, what they prefer, whether it be what's their preference for how they would like to be referred. Is it Jeff, or is it Mr. Bell? And asking those things and how they view their clinical needs in the presentation. I'd like to say I do that every time, and I'm human too, and so I probably don't start every conversation that way, and I should. And so it's an area where I think we're ever endeavoring to improve and to engage with individuals. When a patient is talking about their care in a more stigmatizing fashion, it gets me very curious as to the environments that they've been in, other healthcare providers that they've connected with. And I really sort of try to pause in those sorts of situations and shift the conversation that's to something that's more recovery focused. Maybe I'll ask them about their view of their diagnosis, but I'd love to tell you a little bit about kind of that recovery focus, but I want to make sure I get to all your questions.
Absolutely. So please remind me to get back to that because that's very important. I want to ask you about how you balance clinical accuracy with compassionate language when discussing a diagnosis. Or put another way, what's the difference between sugarcoating a diagnosis and framing it in a more empowering way?
Yeah, it's a great question, and actually it ties into a lot of the shifts that we're seeing in healthcare today. Whereas there used to be two different ways to talk about patients and their clinical needs. You'd talk about it one way when the patient was there, and a different way in your treatment planning and behind closed doors, and maybe with one another as healthcare professionals. And more and more, the field is really moving away from that, not only including patients in the care planning conversations. And so it isn't two different conversations. We're having the same conversation together. And also, how we write about it. And so At times, you you mentioned the term sugarcoating it, and what we try to do is educate individuals with what the diagnosis is, what it means in terms of the clinical terminology, but try not to use so much jargon. Try not to be so technical, but also not devalue or limit the explanation that we have, because we do want to make sure that patients really understand the clinical condition that they're managing. Because the more they're educated on the clinical condition, the better the treatments can be.
What role does language play in destigmatizing, particularly stigmatizing diagnosis? I mean, borderline personality disorder, bipolar disorder, sometimes these can be very stigmatizing.
They can be, and I think that going back to that concept of that the person isn't their diagnosis, that it is just one part of who they are. And, some patients may feel like there is an element of identity to that and to the various experiences that they have had that have led to that diagnosis. I think that um, when we're observing patients' lived experience, that's an important part to bring in to the work. And when it comes to those specific diagnoses that tend to have more stigma attached to them, I think the more we talk about them, the more we open up the stage for people to discuss what it really means to have that particular diagnosis, it really makes a difference. I know there are a number of campaigns and education activities that really sort of reduce the barriers and people feeling comfortable talking about what they're experiencing and what they need, and frankly, what works to help them identify a meaningful recovery.
Christine, let me circle back to your call out for some practical strategies around this. I know that you've brought some to the table here today, and perhaps you can share with us some specific examples of how language has made a difference in your interactions with a particular client or a scenario.
Sure. Well, certainly that example from the emergency department is a meaningful one, because when the whole team is functioning in a way that is seeing the patient first and seeing the patient as a whole, it actually makes those interactions, feel more engaged and really productive and effective. I think, from a practical strategy point, we need to listen to our patients. We should ask them. You asked me, do you ask the patient every time? And I do endeavor to understand what is the way that the patient would wish to be referred to and wish to talk about their diagnosis or their illness. So listen to our patients is really important. I'd say socializing the best practices among the team, actually having conversations like this. Years ago, there was a very strong movement for training in this space. And again, it's focused on recovery-oriented practice, but embedded in recovery-oriented practice is this concept of patient-first language and how language really matters. And so socializing the best practices, making sure that as clinicians, we're aware of those, and frankly, offering that same level of education and insight to our patients to say you can and should expect this anywhere you receive treatment. I think talking with one another makes a difference among your teams, and frankly, holding each other accountable. Just because the door is closed and we begin to have those conversations that may not be as patient-centered as we wish, we hold one another accountable and make sure that our interactions are identical, patient-facing and not.
Yeah, that's such an important point. Let me follow up with you on that in terms of you mentioned the whole care team. And sometimes I'm imagining you have encountered a colleague that might be using some stigmatizing language. Can you give us just an example of how you might even hypothetically address that with a colleague?
Sure. And it's not an easy conversation to have when there's a colleague, and in particular, if it's a peer, can be challenging, and if it's somebody on the treatment team or a supervisor or somebody who holds a little more responsibility in the system, it's really hard to call that out and to call that in when something like that happens. And I've had experiences where either myself or I've observed where somebody maybe gets upset in those moments, and the conversation becomes a little embedded with some friction at times. What I have found works the best is really with due humility, just noting that there might be some other ways that we could, refer to the patient, or that, you have been learning more about patient-centered care and patient-centered language, and, offer an alternative in that moment. But a lot of times just taking that momentum, and instead of having it, be tell how to do it differently, it's actually really, really nice to just pause and say, when I'm talking about patients, I often will use patient first language, a patient with bipolar, and so on. And it just gives that little extra pause in the conversation. And sometimes it lends itself to even more effective conversations as a team.
Christine, we'd be remiss not to address electronic medical records issues, EMR, big part of today's modern healthcare system. How does all that factor into our conversation today about language and its potential to either stigmatize or be more inclusive?
Yeah. Well, it's a really complex topic. I'm glad you're bringing it up because there's a lot to do in this space. I'd say that notion of there used to be two different ways that we would communicate or about patients or with patients. One when the patient was present, and one when the patient was not. And things have changed. And here in the U.S., there's been legislation that actually allows for patients to have immediate access to their electronic health record. And so the type of language that's put into the record should be thought about in a very similar fashion as to when you're talking with patients directly. And so the guidelines around reducing technical terms, reducing jargon to really bridge the gap apply to electronic health records as well. I'd say that there's a lot more work to be done here. There's some wonderful trainings out there for that particular access to the record, and we've got some opportunities to bridge the gap there.
On that note, I wanted to ask you about sort of the evolution of this whole topic and the trend line. Do you find that the field is moving ever more closer to being more inclusive in language?
I think psychiatric mental health settings are moving in that direction, and some of these types of policy changes are helping. Funding when it comes to large-scale training. There was a push many years ago across all of the professional organizations to really talk about recovery-oriented practice, person-first language, and how much language matters. And yet, I still think that we have a long way to go. And while there's been advances in psychiatry and in mental health treatment, when we look at healthcare as a whole, there remains stigma and bias that exists within the care, and it's contributing to gaps in health equity and beyond. So there's more to do.
Here's a specific question for you, Christine. How do cultural and regional differences impact the way that certain mental health terms are perceived, and how should a clinician navigate those?
Yeah, another excellent question. And there's wide variability from cultural and regional perspective, and that could be in a single community. Truth be told, but then when we really expand our view and look globally, there are very different levels of stigma and viewpoints, really, and some of that is really driven by culture, by spiritual beliefs, religious beliefs, by language, and then that point that we were making earlier about how we say certain terms. And so I find that the best way to approach that is with humility and curiosity. No one individual or clinician can actually know everything there is to know. No one person can know everything there is to know about another person's experience. And so asking questions, being curious, and being open to really set the stage for a collaborative conversation, I think is the best approach.
We are speaking to a spectrum of viewers today when it comes to how much experience they might have in the field. Let me ask you about both ends of the spectrum. How do you get buy-in from seasoned professionals who may be resistant to changing their established terminology? We touched on this earlier, but let's use this opportunity to expound a little bit more on that.
We went through a process where we actually rolled out a number of education and training modules, and they got us a ways down the road in introducing the concepts of recovery-oriented practice, person-centered care, identity affirming language, and so on. It got us a little ways down the road. I think people understood the concepts and so on. But the factors that actually helped to move the needle, to really turn the corner, was having conversations with individuals who had lived experience. A person who could come and talk about what it feels like when a stigmatizing word is used, what it feels like when they don't feel engaged in a therapeutic alliance because there's distance between the clinician or others. And so that was a strategy that we used very heavily, and had peer specialists, family members, individuals with lived experience really tell their story. And not only did it bring to life that this is an individual who's so much more than their diagnosis, but it also was a very meaningful presentation of how hurtful language can be when not used properly.
Let's next zero in on the newest folks in our audience in terms of being new to the field. What is a simple, actionable piece of advice that you could give to a new mental health professional who really wants to prioritize compassionate language from day one? What do you say to them?
Thank you for that. And just as you're talking about those new into the field, we know that so often they're being trained by those who are more seasoned, who you just asked me about. And I just want to bring a finer point to my comments that that lived experience presentation did really impact our more seasoned individuals, people who really were had been trained at a time where there was a much different sort of dynamic in clinical care. And so similarly, when training within large groups, those who are new to the profession are going to learn from those seasoned. It really makes a difference what they observe and what the modeling is. And so all too often we're encouraging people when they're new into their career to really take the best practices today, and if they're seeing something that varies from that, to raise their hand. Engage with their leaders and supervisors, because it can be a really lonely place for a brand new clinician who is trying to use a very contemporary approach if they're working in an environment or in a community where stigma is very present. And so I think stay curious and really embrace these best practices.
How would you address a mistake you might have made along the way in terms of offending a patient with language? I'm not suggesting that you have in the past, but I think none of us is perfect. And I'm guessing that along the way, there have been missteps. How would you address that?
Yes. Well, I think there's a spectrum here, because if you are someone who is approaching the work again with that level of openness and curiosity and humility, you are setting the stage for a very collaborative and therapeutic alliance, one that will open things up for people to actually tell you when that's happened. And the notion that you may observe that a patient becomes more reserved or closed, you may ask, um, you know, has our conversation gone okay? Am I getting it right? Those kinds of things. And so I think it's really, really important to be open to hearing about those blind spots, and we all have them. And I can recall an instance where an individual really asked for help about a particular clinical challenge that they were having. And as we started to talk through the conversation, I didn't get it quite right. I was, providing some guidance and feedback based on their question, but I didn't get it quite right, and they told me so. And we took the opportunity to thank them. I was really grateful that they were able to share that didn't feel right, and we talked about what would feel right in that moment.
Well, I love the sense of humility that you are demonstrating at this very moment that you talked about as being such a critical factor, humility and curiosity. So thank you for that. Um, in the final minute that we have left, any resources that you want to pass along for folks who are looking to learn more about this particular topic?
Thank you so much. I think there's a number of things out there. Here in the U.S., the SAMHSA has some tremendous resources related to recovery-oriented practice, and this notion of language matters, and person-first language is really embedded there. And it actually sets a framework for how to engage most effectively or optimally with patients. McLean's own Deconstructing Stigma campaign really has a lot of information about how to approach conversations, and a wealth of resources there. And, as you read people's stories, it actually brings to life who they are beyond just the illness or the condition that they're managing.
Christine, I'm afraid we're out of time. We could do another hour on this. It's such an
Of
important
course.
topic. You have done a fabulous job reminding us of why it is so important to use words and language correctly in patient-centered care. Thank you so much for your time.
Thank you.
Dr.
Take care.
Christine Tibaldi.